Buenas, mi nombre es Juan Granada, presidente del CRF con Columbia University en Nueva York. Es un gran placer para mí presentarles esta nueva serie. En esta serie, en vez de presentar una charla, lo que vamos a hacer es presentarles una discusión que sucedió en el TCT el año pasado, después de la presentación de los datos de COAPT. Es muy interesante porque es un panel que está conformado de cirujanos, de clínicos y de intervencionistas, y básicamente se discute el papel de MitraClip o de reparo valvular percutáneo en estos pacientes con falla cardíaca, poniendo en perspectiva los datos que se presentaron. Este año en el TCT se presentó el seguimiento a 3 años, donde básicamente no habían diferencias significativas en cuanto a los 2 años, que es muy buenas noticias. Y yo estoy seguro de que este tipo de discusiones van a dar una perspectiva muy interesante para lo que se viene en el futuro con el reparo valvular mitral percutáneo, sus indicaciones, sus retos, sus oportunidades y para dónde es que va este campo tan interesante del reparo valvular mínimamente invasivo. Espero, verdad, que lo disfruten y nos vemos en la próxima serie.
I'm Bill Abraham from The Ohio State University, and it's my privilege to moderate this session coming to you from TCT 2018 on secondary or functional mitral regurgitation in heart failure. We're very lucky to have many distinguished participants from the field here, from the fields of heart failure, cardiac surgery, and interventional cardiology to talk about this. And I'd like to start by asking Joann Lindenfeld to talk a little bit about the problem of secondary MR and heart failure. How big of a problem is this? What's the prognosis? And does it make sense to consider intervention here?
Bill, it certainly makes sense to consider intervention. We know that in any clinic of heart failure patients, especially those with reduced EF, the prevalence of mitral regurgitation is high, and the prevalence of moderate to severe mitral regurgitation is probably in the range of 30%. We know that when mitral regurgitation appears at whatever level, the more severe the mitral regurgitation, the more severe the prognosis. We do know that medical and device therapies can improve mitral regurgitation in patients with reduced EF. For example, particularly beta blockers in the medical arena substantially lead to reverse remodeling and a decrease in mitral regurgitation, at least in a fair number of patients. And we also know that CRT can reduce mitral regurgitation substantially in responders, improve EF, decrease end diastolic volume. So there are those therapies. We have a little less information on ACE inhibitors or Entresto or mineralocorticoid receptor antagonists, but there's almost certainly some benefit there. So we see these patients with worsening mitral regurgitation, and presumably if they've already been up-titrated in medical therapy, we know their prognosis is worsened. Those are patients then that we're considering for advanced heart failure therapies such as LVAD or transplant. So in the heart failure world, this is a serious problem when we start to see severe mitral regurgitation in the face of reduced ejection fraction.
Well, thank you. But despite the seriousness of the problem, we as heart failure specialists haven't been referring these patients for surgical mitral valve interventions, repair or replacement. And Mike, any perspective on this from the surgeon standpoint?
Yeah, absolutely. So surgery has been done and can be done for secondary or functional mitral regurgitation. The initial clinical experience with this that demonstrated that surgery could work was by Steve Bowling and the group from the University of Michigan in the 1990s, and the use of an undersized annuloplasty to correct the functional mitral regurgitation. It, however, has never been proved in a randomized trial to make a difference either in quality of life or long-term survival. And one of the problems that has plagued surgery has been the recurrence rate with an annuloplasty, which has led to the concept of perhaps surgical mitral valve replacement may provide a more durable option. So that led to a series of 2 trials between 2010 and 2014 in what's called the Cardiothoracic Surgery Network, sponsored by the NIH. One was in ischemic mitral regurgitation that was severe, and patients were randomized between repair and replacement. That trial showed that replacement was a more durable correction than repair. The second was moderate secondary mitral regurgitation at the time of CABG, and it showed that adding an annuloplasty to revascularization alone did not help. It did change practice, however, in that more patients undergoing a surgery right now for secondary mitral regurgitation get replacement rather than repair. If you look at the whole world of cardiac surgery, about 40,000 mitral valve operations are done a year in the United States. Only 5 to 10% of them are for secondary mitral regurgitation because the results aren't long-lasting. It's a highly morbid procedure in these patients, and there's been no body of evidence that shows that it makes a difference long-term.
Okay, and it's even less common to do isolated mitral valve surgery in those patients, right?
Yeah, this is isolated mitral valve surgery.
Oh, this is isolated, okay.
Yeah, so, but it's a minuscule number compared to the amount of mitral valve surgeries done.
Okay, well, so we're moving into a new era now, and we've got new evidence that's come forth at this meeting, at the TCT meeting, that offers hope to these heart failure patients. And maybe first, Gregg, I'll ask you to address the question which has been debated for many years. You know, is this secondary or functional MR just a marker of disease severity, or does it actually participate in disease progression and contribute directly to the poor outcomes that we see in heart failure patients?
Well, that's a great question, and it's really been an unknown question. I think that in part was answered over the last several days, because we know that the primary etiology of secondary MR is underlying left ventricular dysfunction. That is, the left ventricle dilates because it's either had direct myocardial damage from a heart attack, myocardial infarction, or from ischemic or non-ischemic cardiomyopathy. And when the left ventricle dilates, it actually dislocates the papillary muscles. There's usually apical and lateral dislocation of the papillary muscles that pulls on the cords. It tethers open what's a relatively normal mitral valve, so just the anterior and posterior leaflets can't close or can't coapt. And as a result, you get secondary mitral regurgitation. There can be late changes in the valvular structure, late annular dilatation, but the problem really is the underlying left ventricular dysfunction. And we've known for a long time that if you develop secondary mitral regurgitation, that your prognosis is worse, that patients have higher rates of mortality, heart failure hospitalizations, and a worse quality of life. And that's been an independent predictor in multivariable analysis of all those factors. And it quantitatively, the worse the MR, the worse the prognosis. What we've never known is the MR a biomarker, if you would, of a bad underlying ventricle, which even if you fix that, it doesn't matter. Or does the extra volume overload that the mitral regurgitation then places on the left ventricle truly cause further left ventricular dilatation, further MR, the so-called vicious cycle of secondary MR? And so would therefore correcting it improve the prognosis of the patient? And we almost had to find out by testing it by doing the COAPT trial to see if that would improve outcomes for these patients.
So tell us a little bit about the COAPT trial.
Sure. Well, COAPT was really an extraordinary undertaking, and for which I have to acknowledge Mike Mack, who is the co-principal investigator of the study along with me, and both of you, who as the heart failure specialists and co-principal investigators on this trial, helped us to realize that this was not a surgical trial, of course. It was not really even an interventional trial. It was a heart failure trial. And it was, how do we improve the prognosis of patients with heart failure and secondary MR? And we approached it like that. So we first asked who was the right population to enroll, who may need this therapy. And we took patients who were already receiving all guideline-directed medical therapies and remained symptomatic with New York Heart Association class 2 to 4A, with left ventricular ejection fractions of 20 to 50%, and ventricles which were not excessively dilated. And these were important parameters in the trial because we know that ACE inhibitors or ARBs and beta blockers and mineralocorticoid receptor antagonists improve prognosis in heart failure. And we all believe that's the first line therapy for heart failure with or without MR. And it'll often reduce MR as well. So we took patients who, despite that, needed more to improve their prognosis. And we took 614 such patients from approximately 80 sites in the United States and Canada and randomized them 1-to-1 to the background guideline-directed medical therapy. And by the way, they'd also received cardiac resynchronization therapy if appropriate. That was about 36% of the patients. So background guideline-directed medical therapy with or without MitraClip correction of the mitral regurgitation. And we used sites in the United States and Canada that were relatively skilled with the MitraClip, because after all, this has been around for 10 years now. And a 1-to-1 randomization, so 302 patients were assigned to the MitraClip, and the MitraClip procedure was highly effective in those patients acutely. We had clip implant rates overall in about 95% of patients, and 82% of the patients had 1+ or less MR by echo core lab analysis right at the end of the procedure before discharge, compared to all patients having 3 to 4+ MR. And this was real 3 to 4+ MR. This was the US American Society of Echocardiography criteria. So basically translating to a EROA of greater than 30 millimeters squared, or regurgitant volume greater than 45 mLs per beat, or pulmonary venous flow reversal, etc. So 95% of the patients had less than or equal to 2+ after the MitraClip. And then the primary endpoints of this trial was to see if we could reduce all heart failure hospitalizations within 2-year follow-up. And the primary safety endpoint was the safety of the MitraClip with a composite endpoint compared to an objective performance goal. And after following the patients for 2 years, we found there was approximately a 50% reduction in heart failure hospitalizations. And if you look at the curves spread almost immediately. So by reducing the excess volume overload in the ventricle, we improved quality of life, the patients felt better, they exercised longer distances. These were all secondary endpoints. But importantly, severe heart failure exacerbations were put under control, so patients didn't need to be admitted to the hospital. Again, about a 50% reduction. And then truly remarkably, we saw that as we followed patients for 2 years, mortality was reduced. And we reduced mortality by a relative 38%, but more importantly, an absolute 17 out of 100 patients had their lives saved. So the mortality in the control arm was 46% at 2 years. So almost 25% a year. That's cancer type numbers, showing just how sick these patients were. And that was reduced from 46% to 29%. So while we didn't solve the underlying left ventricular dysfunction and the disease of having an LV cardiomyopathy, we certainly improved the functional status of these patients. We kept them out of the hospital, improved their quality of life, and made them live substantially longer. The number of patients needed to treat to prevent a heart failure hospitalization was 3. The number needed to treat to save a life was 6. So these are very, very low numbers showing the magnitude of the effect. And again, these p-values were all 5 or 6 zeros and a 1. So the magnitude of this effect was very, very robust. And what underlied all of this was the robust reduction in mitral regurgitation, which actually was quite durable through 2 years, which we were very, very pleased to see. And only about 3 to 5% of patients had recurrent severe mitral regurgitation. So the MitraClip tethers the leaflets. Even if there's a little bit more left ventricular dilatation over time, it kept severe mitral regurgitation away for the most part, and that was very gratifying.
Well, those are truly remarkable results, and thanks for reviewing them. I'd like Joann maybe to talk a little bit about some of the other endpoints and what they mean to our patients. We focus on morbidity and mortality, and the numbers are spectacular. But also in the COAPT data are these remarkable improvements in quality of life, in New York Heart Association functional class ranking, and really the mitigation of a progressive decline in exercise capacity seen in the 6-minute hall walk, because we know this is a progressive disease and people become more and more limited with time. And we saw essentially, elimination of that disease progression as measured by the 6-minute hall walk. Well, what does this mean for patients?
Well, this is an incredible win for patients because we always think about hospitalization and mortality, but patients frequently think about shortness of breath. Can they do their normal activities of daily living? Can they go out with friends and family? Can they go to a graduation? So this study demonstrates markedly improved quality of life, ability to exercise longer, to feel better. So you not only live longer, but you enjoy that time. And so I think this is really an important finding.
And put the improvements in morbidity and mortality that Gregg described into context of other heart failure therapies. Is the magnitude of benefit here small or large in the context of heart failure therapies?
The magnitude of benefit is very large. We're very used to seeing remarkable benefits with ACE inhibitors, and particularly the new sacubitril valsartan, beta blockers, mineralocorticoid receptor antagonists, and CRT. But actually the benefit of MitraClip, mortality benefit and hospitalization benefit, is greater than any of those individual therapies. So it's a very large magnitude of benefit.
Fantastic. And greater than but additive too, right?
Greater than but additive too, absolutely.
Talk a little bit, because I think this additive too piece is important, a little bit about what was done in COAPT to assure that patients were on optimal or best tolerated, maximally tolerated, guideline-directed medical therapy. So I think it's such an important message. We don't want to rush and put MitraClips in every heart failure patient who is just sort of starting down the road of GDMT. So how do you optimize therapy? What was done in the trial, and how do you do it clinically?
This was very rigorously done because this was a heart failure trial, as Gregg said, and we wanted to be sure that since these medical therapies can improve mitral regurgitation, that every patient had the maximal medical therapy and device therapy that they could tolerate. So every patient was presented by the investigator at the site, and a review committee of heart failure interventional surgeons reviewed every one of these cases to be sure that the medical therapy was adequately up titrated. And early in the study, we saw that sometimes blood pressures were higher than some people might be comfortable with vasodilators, but we insisted on those being added as well, and added the mineralocorticoid receptor antagonists. And every patient who was eligible for CRT had CRT. There were a number of cases where patients had been recently paced, and their ICD started to pace them, and we asked that the pacing rate be turned down, and many of those patients improved. So this was an incredibly rigorous review of every single case. Many of the patients were turned down because it wasn't felt that their medical therapy was adequate, and some came back. We said, we want to maximize the medical therapy, but you can come back in 3 months, and that was done as well.
Fantastic. And Mike, from your perspective, is this wow? I mean, is this like, big and bigger than what you've ever seen in other trials? I mean,
so the answer is absolutely yes. As Joann said, the magnitude of benefit here is greater than any other previous known therapy for heart failure. And if you think of trials in clinical medicine, this is a new treatment for a disease that hasn't had treatment before from an interventional or surgical standpoint. So you can make it wouldn't be hyperbolic to make the comparison to the original partner trial in inoperable patients of treating inoperable patients with aortic stenosis with TAVR. This is as profound as that, if not more so, because it does offer both survival and quality of life to patients that didn't have an option to that before. And more important than that, we do have evidence that it absolutely makes a difference. The concern about randomized trials is how long they take to enroll, how expensive they are, and when they're done, are they generalizable to the population at large? And I have always said that the randomized trials and the robust body of evidence actually accelerates clinical adoption of a new therapy when you have evidence as strong as this. And we all lived through 8 years of this trial, 4.5 years of enrollment. There were a lot of dark days when we wondered whether it would ever get done. We wondered when the trial sponsor was going to pull the plug on the funding for it. But at the end of the day, you can see how much this means and is going to mean to clinical medicine going forwards. And this is not the end, it's just the beginning. You know, it's the first toe in the water of a new options for treatment of patients with secondary mitral regurgitation. And, you know, we know a lot more than we did day before yesterday, but not nearly as much as we need to know tomorrow and the upcoming months and years.
Yeah, I think that's a great point. We're still learning a lot. One of the things that impressed me most, and Gregg's already referred to it, is the absolute reduction in risk. You know, we talk a lot about relative risk reductions. We see in the heart failure arena, in drug trials, you know, studies in many thousands of patients that demonstrate what look like substantial relative risk reductions, but that's on top of a very small absolute risk reduction, you know, of a couple or a few percent. But a 17% absolute risk reduction in all-cause mortality is huge. And I don't know that we've seen that in any other trial in heart failure. I mean, it really is truly remarkable, and this is going to save a lot of lives. And from my standpoint, you know, like Joann, I think the patient wants to feel better first and foremost. And this therapy offers them the opportunity to feel better. But in addition to that, saving lives is important and really creates more of an ethical mandate to get these therapies to our patients.
So what's this going to do to the heart failure community, Bill?
Yeah, great question.
Are they going to embrace this? Or?
I think the heart failure community will embrace this. You know, the heart failure community, I think like our cardiology community in general, we're very evidence-based, you know, with no evidence that had ever demonstrated in an adequately powered randomized controlled trial that reduction of MR in heart failure patients improve clinical outcomes. We've been very conservative over the years. We've not wanted to subject our patients to the risks of a surgical procedure, or even with the advent of some of the percutaneous approaches to, you know, those potential risks, even though they're quite low, until we had this clinical trials data. You know, now I think the heart failure community has gotten what it asked for in the COAPT trial. So my expectations are quite high, quite positive that this will be embraced. What do you think, Joann?
I think if Twitter is any indication, the heart failure world has already embraced it.
You know, Bill, I'll make one other important
Please.
point, and that is that, you know, in the trial, pretty much every subgroup we looked at benefited. And because in my mind, the real question is who should be getting a mitral clip, as you were saying before, with heart failure and secondary MR. And when we looked within the trial, men and women benefited, younger and older patients benefited, patients with lower and slightly higher left ventricular ejection fractions between the range of 20 to 50% that we enrolled, patients who were considered low and high surgical risk, ischemic or non-ischemic cardiomyopathy benefited. But we found one small tiny subgroup that didn't benefit, and those were patients that had lesser degrees of mitral regurgitation whose ventricles were on the more dilated side. And that's consistent with some other data that we've seen recently as well. So, you know, in summary, I think that patients who can really benefit from their reduction in mitral regurgitation are those who first have dilated ventricles, but not too dilated, and have a large amount of volumetric mitral regurgitation such that reducing that volume is going to truly impact the over volumetric status of the patient. So we're talking in general, an EROA of greater than 30 millimeters squared, you know, left ventricular indexed end diastolic volumes per millimeter squared, probably on the order of 120 or so or less, but not 140, 150 or 60. Severe mitral regurgitation. And then patients who have really been tried on all maximally tolerated doses of guideline-directed medical therapy to make sure that that alone doesn't make them better. Because we saw many such patients that were submitted to the COAPT trial who were not on optimized therapy. We said, put them on optimized therapy and then come back to us if they don't get better. And a lot of them got better. Their MR was reduced, they became asymptomatic. So we need symptomatic patients who have already been tried on CRT and all heart failure medical therapies that they can tolerate, who still have New York Heart Association class 2 to 4A symptoms, ejection fractions of 20 to 50%, and again, true 3 to 4 plus MR as we define it here in the United States. And those patients, I think, should get this procedure with this device and can have tremendous benefits in quality of life, freedom from hospitalization, and improved years of life as well.
Yeah, fantastic.
I think, Bill, too, one thing that Gregg talked about, the subgroups, two subgroups that were really important is there were plenty of women in this trial. Women are often underrepresented. And this was an older age group, and we are much older than most regular heart failure trials.
72.
Yeah, 72 instead of the usual 65 or 66. So I don't think we need to worry that women won't benefit, that older patients won't benefit. I think those were important subgroups.
Yes, absolutely. And Gregg, I think this, this discussion around ideal patient and this balance between severity of MR, severity of the LV dysfunction is really important because we've debated for years, is this a ventricular problem, a valvular problem? It's really both, but there probably is a tipping point where the ventricular problem predominates, and if I hear you correctly, the patients who have worse ventricles and less MR are less likely to benefit. Those who have perhaps ventricles that are a little bit better, as judged by LV end systolic volume, for example, and have more severe MR, that seems to be the sweet spot, the COAPT population, the group of patients who really benefit most.
Exactly, and we had thought about that ahead of time. Sometimes you can be too smart for your own good, and in this case I think we did enroll, for the most part, the sweet spot of the patients who are sick but not too sick in terms of left ventricular function. Ventricles were somewhat dilated but not too dilated, and they did all have severe mitral regurgitation, and that certainly is the key.
So contrast that population, the COAPT population, against the MITRA-FR population. I think we've got to talk about it because it stands out there now as a negative study, but they're different studies.
Right, so a previous study that had come out about a month earlier, the MITRA-FR study from France, it was about half the size. It randomized 304 patients, and they were patients with heart failure who had severe mitral regurgitation, but using European criteria. And this isn't a US-European thing, but the European criteria suggested that the amount of volumetric MR you get in heart failure, as opposed to primary MR, may be less, and maybe just as prognostically important. So they had traditionally used criteria for severe mitral regurgitation in heart failure of an EROA of greater than 20 millimeters squared, or regurgitant volume of greater than 30 millimeters per beat. So that's what we would call moderate in the United States, but that was called severe in Europe. So they enrolled 304 patients with similar symptomatology, similar ventricular function as in COAPT, but as it turns out, also substantially more dilated ventricles. Even though the left ventricular ejection fractions were similar, the ventricles were dilated and they had substantially lower degrees of mitral regurgitation. The mean EROA, effective regurgitant orifice area, in MITRA-FR was 31 millimeters squared versus 41 millimeters squared in COAPT. And MITRA-FR looked at 1 year outcome of death or heart failure hospitalization, and it was a negative trial. So we actually, to understand that, went back within the COAPT population, and we interestingly were able to replicate the results. When we looked at patients who had lesser degrees of mitral regurgitation, and we did have a few that get in with an EROA of less than 30 millimeters squared, and if you looked at those patients who had a small ventricle, they still did well in COAPT. But the patients in COAPT who had a ventricle that was on the larger side, that did not have a lot of regurgitant volume, they had no effect of the mitral clip. So I think we've been able to reconcile this. There were other differences between the trials. The medical therapy was more standardized in COAPT, where it fluctuated more, we believe, in MITRA-FR, and the outcomes of the mitral clip operators were better in COAPT. The clip implant rate was higher, the acute reduction in MR was greater, the complication rate was lower, and the durability of the mitral clip was greater in the US and Canadian operators, because they had been using the device for 10 years, whereas the French operators were relatively new to the mitral clip. So when you put all this together, it gives you a picture of which patients are going to benefit if you have experienced operators, if you've already failed guideline-directed medical therapy, you have truly severe MR, and you don't have what we've called a blown left ventricle, which is dilated and has so little contractile reserve that it can't recover.
Well, it makes sense. And Mike, please.
So one of the things that Gregg mentioned, and I think all among ourselves have discussed, one of the reasons this trial was so positive is that it was MitraClip on top of a foundation of maximal guideline-directed medical therapy. And as I mentioned before, one of the issues of a generalizability of a trial to the real world is maintaining what was done in the trial, from expertise in operators to guideline-directed medical therapy. It seems to me one of the biggest concerns are the slippery slope of guideline-directed medical therapy not being as robust in the real world and people going right to MitraClip, and how do we assure that that's the case, and are there enough heart failure specialists out there to manage these patients, or do there need to be heart failure specialists managing all these patients first?
Yeah, great questions. Joann, you want to tackle
well,
that?
there are only about 1,000 or slightly less advanced heart failure physicians in the United States, but there are a number of other cardiologists who have a special interest, and I do think it's clear in the United States that medical therapy is poorly applied. There was just a study, CHAMP, published in JACC, that demonstrated that less than 1% of all heart failure with reduced EF patients in the United States have maximally up-titrated doses of all the medical therapies.
Less than 1%?
When you take them all, if you put them all together now, each one is about, a third are not adequately up-titrated. So I think what we are going to have is maybe not a heart failure specialist, but someone with a special interest in the medical therapy and heart failure, just seeing these patients and making sure that each patient is adequately up-titrated. And I think the lessons to be learned are that a blood pressure of 120 is plenty of blood pressure for most of these patients. And a creatinine of 1.6 is not that high.
So, coming into this webcast, I already knew we needed more expert mitral valve surgeons. But heart failure is the #1 cause of hospitalizations in the United States, of resource utilization. How can we have so few heart failure specialists? I didn't know that. Yeah. We need more heart failure specialists that have expertise that can really give better care to these patients.
I think that's really true, especially now. We have several monitoring devices for heart failure.
Yeah.
We now have MitraClip, which is great, but we also have a treatment for central sleep apnea. We have a cardiac contractility device. And there are, as we've seen in this meeting, incredibly exciting the first day were all the devices that people are developing for heart failure. So I think we are going to need more people who see the broad spectrum of these patients and the types of therapies that can be applied to these patients.
Is the specialty growing?
The specialty is growing, but I think, also what I think COAPT really shows us is that we are going to need, as we've done for a long time with structural heart disease, we need a group of people. We need interventionalists, we need surgeons, we need heart failure doctors, and we need imagers that can give us the very precise echo data that we need to have to really be sure we know who's a good candidate. So it isn't just the heart failure expert. We're really going to have to make our echo, I think the readings that we usually see, just much more granular in the detail that we get.
Yeah, I would add for all the young up-and-coming cardiologists in the audience, residents, cardiology fellows, even those who are just starting out in their career, that there is a high need for heart failure specialists. I get calls every week from other places, looking to recruit heart failure specialists. So they really are in demand. It's a wonderful field, and I think now that we have married, heart failure pharmacological therapies with devices. We did that starting many years ago with ICDs and CRT, but now I think with the COAPT trial and the MitraClip experience, the ability to have people operating at this interface between heart failure and interventional cardiology and being part of this multidisciplinary heart team that will be able to optimize GDMT and offer these device therapies to patients is really exciting.
It is.
So I hope young folks out there are paying attention to this and will consider careers in heart failure.
So, I described the COAPT trial as a new dawn for patients with heart failure and secondary mitral regurgitation to really offer the hope to many of these suffering, desperate patients. But it's also a new dawn, I think, for the multidisciplinary collaboration that this quadrad, that's not a triad, whatever that word represents here, and working with the three of you for the last 8 years has been really a privilege, but it's also been a joy. And I think we've all learned from each other, and to bring our different experiences, ultimately it's patients who are going to benefit by getting the expertise from all the different disciplines, and that's what needs to go on in the future.
Absolutely.
Absolutely.
Absolutely. And coming back to the GDMT, question that you raise, I think our incremental therapies, our additive therapies, adding a MitraClip on top of medical therapy, likely work best when you really are on optimized drug therapy. There are likely to be synergies here, and we didn't talk about it in MITRA-FR, and we actually don't know because the data wasn't collected. But the approach to both baseline GDMT as well as post-randomization changes in GDMT was very different in that trial. And it's possible that reducing FMR without optimizing GDMT might be less effective. So I think we really have to promote this notion of optimizing GDMT. The other reason is, and Joann's already mentioned it, that some patients do get better with GDMT. They get better enough that they might not need a device-based therapy. We've learned that with CRT and with ICDs, and we still see today patients who come in on very inadequate GDMT, but they've already gotten their defibrillator, for example, and then we optimize their GDMT and their ejection fraction goes to 45 or 50%, and in retrospect, they never would have needed that primary prevention ICD. So I think we want to get device therapies to those patients who really need them, and we want to try to avoid them in those patients who can be made better with guideline-directed medical therapy. And we just have to promote that paradigm, that algorithm, and we've got to go out and teach people about it.
Yeah, I think the other really exciting thing here is that we saw some patients that entered COAPT who weren't on full therapy because they were intolerant, for instance, hyperkalemia, hypotension. But I think we now have a chance to have a person, the heart failure person or a person with a special interest in that, following COAPT, if there were people who, following the MitraClip, if there were people who couldn't tolerate full therapy. Can you go back and advance that? Because that is very likely to be beneficial. That wasn't done very much in COAPT by design, but we really need to go back and very carefully see these patients now that they get better. It is very likely that we'll be able to up-titrate those who couldn't have full medical therapy back up, and that is likely, I think, to provide additional benefit.
And conversely, there may be some patients actually whose ejection fractions rise and get sufficiently better that some of the medications can actually be down-titrated. So I think you're going to see both possibilities.
Particularly diuretics, yeah, absolutely.
So how do you know what to do afterwards? Somebody gets a MitraClip, their blood pressure comes up, they feel better. Do you up-titrate or down-titrate medical therapy? And how do you know which to do?
Well, I would always up-titrate medical therapy as long as their EF is still relatively low. And you could make the argument, if they have primarily myocardial disease with the mitral regurgitation being superimposed, that you would want to get them on the maximum. So the best thing, though, is that if you can down-titrate diuretics while you're up-titrating the other medical therapy, that really means they're better. It tells you clearly they're going to have a better prognosis. So many of these patients have renal insufficiency, and that improves. With the that'll probably improve. We didn't see it, but as you can up-titrate those therapies, then hopefully, if they're truly better, you'll be able to down-titrate their diuretics, which indicates an improved prognosis.
A new day has dawned.
Absolutely.
It's exciting.
So we focused a lot on MitraClip and the COAPT trial because that's the big news and the first trial ever in this space to demonstrate efficacy. But for fair balance sake, let's just talk briefly about what else is coming down the road in the future. Percutaneous replacement devices, other approaches to repair. Should we expect some promise there as well?
Well, you might want to talk about the other transcatheter mitral valve repair, replacement devices that are on the very quick, early horizon.
Well, I think that the brief answer to the question is this a rising tide that floats all boats, or does it float just one boat, MitraClip? And I think there's so much enthusiasm right now over MitraClip that is totally appropriate. So there is this groundswell of enthusiasm around that, and appropriately so, and that's where we're going to be focused, because we know it's safe and there's a strong body of evidence that patients benefit from this. So the risk-benefit ratio is strongly in the favor of MitraClip. However, we can't extrapolate the results of MitraClip to other repair or replacement devices or surgery, for that matter. However, this will lead to a halo effect of increasing referral of patients. There's a lot of patients that can't be treated with MitraClip, and there's a huge pipeline of both transcatheter mitral valve repair and replacement devices that we need to figure out how this fixed in the whole panoply of treatment of heart failure patients with severe mitral regurgitation. As I said before, this isn't the end. Mm-hmm. It isn't the beginning of the end, it's the end of the beginning.
Exactly.
So, I can expand on that too, that, there are a variety of transcatheter, for example, annuloplasty devices that are under very active investigation and even within pivotal trials. One effect that the COAPT trial is going to have is probably require some revision of what those trials look like, because I believe, and I think most people are going to believe, that patients who would become eligible for the MitraClip, or who are eligible for the MitraClip, that would really be the new standard of care. It would be hard to withhold that as a possibility. Mm-hmm. Now, annuloplasty may have other benefits, may have some disadvantages. The MitraClip has set a high bar for patients who are anatomically eligible and appropriate for its use now in terms of its efficacy and durability. But it doesn't work in everyone. And as Mike alluded to, maybe only 60% or 2/3 of patients will have the anatomy that can be treated by the MitraClip. Mm-hmm. So there will be other devices that may have a role, and annuloplasty on top of a MitraClip may also have some advantages, or for MitraClip failures. Mm-hmm. And then finally, there's a whole exciting field of transcatheter mitral valve replacement right now, which are being done mostly transapically through a surgical procedure, but which are starting to be done through a transseptal procedure, through transfemoral or other vascular approaches. And those offer to have potentially better efficacy than the MitraClip because they can eliminate mitral regurgitation. The MitraClip usually either moderately or markedly reduces MR, but doesn't usually eliminate it. So those devices will be perhaps applicable to a wider range of anatomies than the MitraClip are, and again have the potential to truly eliminate mitral regurgitation, but perhaps they're more complex and there potentially are safety concerns for the procedures, whereas the MitraClip is an extremely safe procedure during the initial procedure. So I think this has created a whole new field. We'll have different types of studies that are being done, different comparators of what is now the standard of care control versus other therapies. The MitraClip will be in the discussion pretty much for every one of these trials. Mm-hmm. And ultimately, I'm very excited about what is to come, because hopefully we will find either a device or a surgical approach or an optimal medical approach for the vast majority of patients with heart failure and mitral regurgitation.
So let's go down the line here and just get an opinion from each of you for future clinical trials that target the COAPT population in patients who meet the anatomical prerequisites for MitraClip. Control arm should be MitraClip?
I think so. I think it has to be.
Okay, Mike?
So I think that the answer is yes. What to my mind is the biggest quandary right now is it's going to be at least a year before MitraClip for secondary mitral regurgitation receives FDA approval and CMS reimbursement. And therefore, it's not an approved standard of care, therefore it can't serve as a comparator in a trial. So what do we do in the meantime, and what do we do with the current trials that are ongoing right now?
Yeah, great issue. Let's come back to that in a second. What do you think the comparator should be
without wanting to sound less than humble, I don't need the FDA or CMS to tell me what the standard of care is. From this trial, in my mind, the MitraClip is now the standard of care, in my opinion.
But for your trial?
For my trial, yes. I don't think it would be ethical right now to bring patients into a trial who meet anatomic eligibility for the MitraClip and other criteria and not offer them the MitraClip. I don't know how I could do that as a caring, meaning physician. So I think that's going to be a challenge. I'm hopeful that FDA will act relatively quickly on this. We're already thinking of how to have the appropriate discussions of CMS, but this was a big story on the front page of the New York Times today, talking about the huge improvement for patients with heart failure. And I think even CMS, who have under the new director Verma, have a new priority to try to make decisions that are truly patient-oriented, to be able to pay for therapies that can improve patient lives. Hopefully they will feel an imperative to move relatively quickly in this. So I know even here there are investigator meetings going on about how clinical trials are going to need to be redesigned given these results. So that's my opinion.
Well, I think that's a great segue to our summary. We're running out of time, but you brought this back to the patient, where it deserves to be. And certainly, I think COAPT has shown us that we now have a new tool in our armamentarium that makes patients feel better, that helps keep them out of the hospital, and that prolongs their survival. And I'd say from a heart failure doc's perspective, what more could you ask for? So with that, I'd like to thank you for your time and for joining me and having such a lively discussion about the COAPT trial and the role of MitraClip in secondary MR and heart failure patients.
Thanks, Bill.
Thanks, Bill.
Thank you.